Coming to SVC obstruction, the SVC obstruction is presented with what is known as the superior vena cava syndrome. It consists of constellation of signs and symptoms which is due to the partial obstruction or complete obstruction of blood flow in the superior vena cava. It is most commonly secondary to external compression or invasion by any tumor or constriction by external or thrombosis. The SVC is most prone for the obstruction because it is a low pressure valveless thin walled vessel which is compliant and easily compressible. It receives blood from both right and left brachiocephalic veins, and it leads into the atrium, which is 6 to 8 centimeter in length, and it receives blood both from the head, neck, upper extremities, and the upper thorax region. Superiorly, it is entered by the azygous vein, which forms a tributary in case of an obstruction, and it is surrounded by tough structures such as sternum, trachea, right mainstem, bronchus, aorta, for which it does not allow to expand in case of an obstruction. So coming to anatomy and pathophysiology, usually the gradually developing SVC obstruction leads to a venous collateral circulation may develop over the chest wall as seen in this slide. The azygous venous system is the most important alternative pathway to provide blood to that area. However, other collateral systems like that internal mammary veins, lateral thoracic vein can participate. Despite having these collateral pathways in a gradually developing SVC obstruction, the venous pressure is almost always elevated in these cases. However, the clinical presentation is mainly due to increased venous pressure in the upper body, which present like edema in the head and neck region, upper torso, upper extremities, which present with a visibly dilated veins and with presence of sinus and plethora of the face. Moderate obstruction can lead to functional impairment also, like dysphagia and cough because of the obstruction to the trachea. Mild or moderate impairment of head, jaw, eyelids movement because of the edema, and the visual disturbance caused by the ocular edema. In cases of severe obstruction, it can lead to cerebral edema with headache and dizziness. In mild to moderate laryngeal edema can cause cough and hoarseness of voice and diminished cardiac reserve, which can lead to syncope after bending. In life-threatening obstruction, the significant cerebral edema present with confusion, obtundation, significant laryngeal edema presenting with a stridor, and significant hemodynamic compromise, where syncope can precipitate without any precipitating factors. The most common clinical symptoms which the patient presents is with the dyspnea and facial swelling and fullness of the head, which is more than in 50% of cases. Other common findings are cough, arm swelling, chest pain, and dysphagia. Infrequently presentation when there is a long-standing SVCS, there can be presentation of the esophageal varices with may be present with bleeding also. However, the distension of vessel of the subcutaneous tissue takes several weeks to develop. So patient developing an esophageal varices of subcutaneous vessels, it will be a long-lasting SVC obstruction. A grading system had been proposed, which shows that usually a symptomatic presentation is approximately in 10% cases where only mild radiographic presence could be there. However, in mild cases, there is 25% of patient who present are 50% are with moderate edema in the head and neck with functional impairment. Findings which are seen usually are the venous distension of the neck and the venous distension of the chest wall, which is also present more than 50% of the cases. Facial edema, cyanosis, plethora of face, and edema of arms are other unusual presentations. The presentation may be aggravated by bending forward, stooping, or lying down. A specific sign known as the Pemberton sign is seen, in which a patient has been asked to elevate both his arms above his head for a minute, and which leads to the presence of facial congestion, cyanosis, and respiratory distress. Rarely life-threatening symptoms such as confusion, obtundation, stridor, syncope without precipitating factors, hypotension, or renal insufficiency can present. The most cases reported in the past were due to syphilitic aneurysm when it was first reported in 1947 by William Hunter. However, now the most common cause is malignant disease, which is the most common cause in present scenario, and of which the lung cancer is the maximum cases present with the lung cancer, followed by lymphoma and other malignancies. So intrathoracic malignancy account for almost 60 to 85% of SVC syndrome. And in almost 60% of cases having lung cancer, the SVC obstruction may be a presenting symptom in an undiagnosed tumor. So non-small cell lung cancer account about 50% of these cases, small cell lung cancer about 25 to 35%, and non-Hodgkin lymphoma 10 to 15%. Overall, these constitute around 90 to 95% of cases presenting with this syndrome. There may be other non-malignant causes which may lead to the SVCS, which may be thrombosis of central venous catheter, intrathoracic goiter, mediastinal fibrosis, sarcoidosis, lymphadenopathies, and rare non-malignant causes like inflammatory vascular condition. Initially, the diagnostic evaluation is doing a chest radiograph may provide a limited information in which a SVC is suspected. However, it can reveal the evidence of mass perihilar lymphadenopathy and mediastinal disease as in this slide. Venography was once thought to be a gold standard for diagnosis. However, presently it can provide information about the exact location of the obstruction, though it is not performed frequently. Today, the present investigation of choice, which is now considered as a gold standard in diagnosing SVCS, is an CT with a contrast. It provides important diagnostic information regarding the cause and can guide us to the treatment. It also determines whether there is an external compression, a thrombus, or a both. If it is caused by a malignancy, it can provide a diagnostic and staging information about that malignancy. The sensitivity and specificity of CT has been 96%, 92% respectively. And it can be clearly seen here that the CT provides a better resolution with respect to an X-ray chest for diagnosis of a part of the thrombus and the obstruction. Other modalities that can be used for diagnosis may be ultrasound, which can be done at the bedside, which can show us the presence of the extent of the thrombosis to the point of obstruction. However, SVC cannot be visualized in an ultrasound, but the waveform in the subclavian and brachiocephalic veins show dampening, and that can help us to guide that there is an obstruction in the SVC. MRI, however, is useful in emergency settings when patients are allergic to contrast or have renal failure. So, a CECT test is the most useful imaging study in detecting the underlying cause, which may help us guide doing a guided biopsy and also assess the level of obstruction. Other selective invasive diagnostic processes which can help in arriving at diagnosis are cytology of sputum or bronchial washings, thoracocentesis for pleural effusions, and needle biopsy of any palpable lymph nodes which can be seen. Although in the past SVCS was considered as a potentially life-threatening medical emergency, however, it is presently an urgency and appropriate care should be instituted. The treatment strategy includes purely symptomatic review of SVCS and treatment of the underlying cause. The most common treatment modality usually consists of the steroids therapy, chemotherapy, external beam radiotherapy, insertion of expandable metal stents into the superior vena cava without thrombolysis or anticoagulation, or any combination of these treatments. However, the mainstay of symptomatic treatment includes an elevation of the head, use of diuretics, and often course of parenteral steroids. Now, the radiotherapy is an effective treatment for SVCS. However, the radiotherapy as to the patient in the non-small cell lung cancer having SVCS. Chemotherapy is an effective treatment for SVCS. Chemotherapy also standard of care in patients having lymphoma having SVCS, and also in case of small cell lung cancers. Endovascular metallic expandable stents can be considered to provide rapid symptomatic relief in patients suspected of malignancies with investigation and histology pending. However, it should be recommended in persistent or recurrent SVCS after failing chemotherapy or radiotherapy. Steroids are being routinely used in the management of FCCO. However, there is no evidence to substantiate or refute the use of steroids in these cases. However, conventionally, the steroids have also been used with the radiation to reduce the radiation-induced edema in these cases. The surgical intervention in form of vascular grafting has a limited role in management of malignant SVCS owing to favorable response to chemotherapy or radiotherapy and increased morbidity of mortality from the surgery. However, in highly selected population, like advanced intrathoracic disease after chemotherapy or radiotherapy failure, surgical salvage may be considered. To conclude, the diagnosis of SVCS is mainly based on clinical findings. Facial puffiness and neck swelling are the most common presenting symptoms. The presentation may be acute, which will present within few days, or subacute over 6 weeks, or chronic more than 6 weeks, depending upon the rate and narrowing of the SVC. Acute cases, the collateral formation is less pronounced and more symptoms are present than subacute and chronic cases, where there is sufficient time to develop the expansion of the collaterals. A slow-growing tumor, long-lasting, causes severe SVC obstruction can sometimes be found without significant related signs and symptoms. The symptomatic relief of SVCS and treatment of the underlying cause is the main management. Thank you.